Welcome everyone to the webinar on FLS Champion Global Success Stories. I am Muriel. I work at the International Osteoporosis Foundation, mainly on the Capture the Fracture program, and it's my pleasure to be your moderator today. We have two outstanding speakers today, Dr. Kasim Javed from Oxford University and Dr. Manju Chandran from Singapore General Hospital. They both set up their own FLS in 2008, and they've been helping on setting up more FLS in their respective countries and internationally. So it's very exciting to hear about their experience and how did they overcome barriers. Just to let you know, questions will be asked after both presentation, but you're very welcome to type them in the question box during the presentation, and I will be collecting them and voice them later. So now I'll start with Dr. Kasim Javed, who is also the co-chair of the Capture the Fracture program. Over to you, Kasim. Thank you.
Thank you very much, Muriel. Welcome, everybody. I think in the last 3 webinars, we've been trying to communicate the strategy for setting up FLS, and this webinar is really based around practical experiences from 2 really great centres, from Oxford and from Singapore. So just to kick off with some background to the UK, population is about 60 million, 3 million osteoporotic women with 300,000 fractures per year, and nationally we think there's 20% FLS coverage. As you may know, the NHS was set up many years ago by Mr. Bevan, and it was set up as comprehensive care, free at the point of delivery and funded through taxation. This has gone through many iterations, and as many healthcare systems change, so do the structures, and we need to know these structures to getting our FLSs funded. So the $146 billion of UK expenditure within the NHS is split up into blue general care and red specialist care, which then goes into the hospitals via different structures. And it's really this group called the CCG, or clinical commissioning groups, that are involved in funding many FLSs in the country. Oxford's got the worst case scenario for an FLS because it's a large area of the country and it has 3 different hospitals. There's the major trauma centre that sees about 2,500 fractures a year, and then 30 miles north, or an hour and a half by public transport, is a general hospital that sees fewer patients, and then our DEXA machines in a 3rd hospital that's close to the major trauma centre, but many miles away from the general hospital. And as with many hospitals, the main issue is parking. So how do you get a good FLS? We've gone through political prioritisation, getting funded, getting started, but it's really about learning from the mistakes of others and also learning from what's worked very well. Within the UK, the prioritisation for Battle Liaison Service really started in 2009 with the Department of Health pyramid, which you may have seen before, which highlights the importance of secondary fracture prevention within the entire programme of work for falls and fragility fractures. This then led to the Capture the Fracture Best Practice Tariff and Reward Programme on the map, as you can see here, with associated toolkits and resources. This in the last year was modified for national standards funded by our local National Osteoporosis Society. And what we've been able to do in the UK is really work with all of these different structures, both in the Capture the Fracture, Public Health England, the charities, our professional organisations, to help commissioning of effective services so the right patient gets the right treatment and they have a lower risk of refracture. So nationally, what we found works very well is to have a top-down approach. So everyone who's government, policy makers, regional directors and hospital directors has the same message, but also bottom-up, where we give information and advice and mentoring to local hospital champions and local community champions so they can meet in the middle to design their most effective service. Most recently, we've been able to set up 3 national audits. The National Hip Fracture Database is existing for many years now and is really our star audit. We last year introduced an inpatient falls audit, and in 2016 have created a specific audit for secondary fracture prevention. So that's the national picture. Regionally, what we found very helpful was to set up a clinical network, Fracture Reduction and South Central Policy Group. It's 11 hospitals, And we have one aim, that every patient over the age of 50 who fractures in this large area of 4.3 million people is identified, assessed, and treated effectively for at least 5 years for both bone and falls health. The benefits of such a regional organisation is one can do regional mapping of needs assessment. And here we have the main hospitals and what they provide for secondary fracture prevention for hip fractures, non-hip fracture in patients, outpatients and spine fractures. And you can see there are only 2 hospitals had a hip fracture service in 2009. Some were trying to start in orange, but most of it was red. Compare this with the picture from our last meeting, where we can see there's now almost universal coverage of hip fractures and nearly a majority of non-hip fractures and also some outpatient fractures, and still a significant care gap in vertebral fractures. Another thing that helped us set up an effective effort is that we developed shared guidelines on tricky issues like how to manage atypical fractures, when to use vitamin D therapy, how long to treat for, and how to monitor patients. And by all 11 hospitals signing up to the same pathway, it made it much easier for us to get this implemented into clinical care. So how do we decide the most effective model for Oxford? The question's quite simple. You need people to go into the service, have a lower risk of refracture, and then this leads to savings which can then invest in the service. But it's actually very complicated. These patients fracture in hospitals, need to be assessed, often started and continued treatment in the community, and monitoring is a major issue. Without doubt, there are some excellent FLS services in the country and in the world, but there's also a feeling that not every FLS is automatically effective. And the last 3 webinars have set out the criteria standards, the audit services feedback that can inform service commissioning and service funding. What we're now going to do is share the Oxford model. So we took a systems approach to this, where we identified the population we wanted to serve and came up with a single high-level aim that everyone is identified, investigated, initiated and monitored for 5 years for both bone and falls health. The first step we did was a stakeholder map, and I'll show this now. We looked at everyone who was involved in this pathway, from hospitals in terms of clinical departments, radiology, information sources from coding and audit, and from the trust executive in terms of finance, managers, and directorate leads. From our funders, who are the people we need to engage with? Who are the funding board, and who are the other associated bodies that can help guide the funders to fund an FLS? For community served primary care, who are the GPs, the nurses, and the allied health professionals. But at every meeting, we made sure we had at least 1 or 2 patients who could represent not only the patient voice, but the carer voice, and also that of the charities. And by having involvement from all of these important sectors, made us a very competitive application to get funded. So what did we want to get funded? Well, it was simple. We had to find the best way to identify, investigate, initiate, and monitor patients. But it had to be minimally disruptive, and I'll describe this to you now. This is a relatively new concept coming from Carl May from one of our units in England, in Southampton, and this is a picture of his mother's interactions with other people in her life one day before she had a hip fracture. Her interactions with the family doctor, her family, and also the person who helped her where she lived in sheltered accommodation. This is her map 2 days before discharge after a hip fracture. It's a very complicated map. The patient now has to interact with many different providers, as well as the family also interacting with these providers. And the real challenge for us is to insert a fracture liaison service that doesn't add extra burden to this pathway. In fact, the patient shouldn't notice this as an extra service that see as part of normal clinical care. To achieve this, it's very important to understand your local patient flow, from emergency care, in-hospital assessment and clinics, to where they live in the community. Understand the volume and where they visit in terms of hospital GP visits and the type of outpatient clinic. But also identify specific types of patients who don't fit into this group, those with pelvic fractures, spine fractures, and those who are already in hospital when they fracture. Once you've got this map in mind, we then create this flow diagram where these are the patients who fracture in the community, come into the hospital, and then are discharged. And you can put in the different stages for identification, investigation, initiation, monitoring to these patients to help you design where to put the staff to have the biggest benefit. So for our major trauma centre, we see every patient while they're in trauma, either in the ward or in the clinic, for a first impression of we are going to keep looking after you to reduce your risk of refracture. The patient knows this is an ongoing relationship. That's what we want to do, and the key step is to pilot it. Fracture clinics in many hospitals are very busy, wards are very busy, and often there are orthopedics, the trauma nurse, the OT and physiotherapists, the plaster technician, radiology, are all busily around the patient, and the question is, how do you fit in the fracture liaison service? You may need to find out issues of space, when's the best time to assess, in the morning or the evening, how you're going to identify patients, who, when, and who's going to check the blood results, and how you're going to set up your DEXA pathway for those that need DEXA. After 2 pilots, we came up with this very simplified high-level pathway. And any patient who fractured in the ward or was seen in the clinic who was over 75 would be assessed and recommended treatment then. They will then have the recommendation sent to their patient and to the GP, and they'll be monitored for 4 and 12 months. For those under 75, they'll be identified, referred for DEXA scanning, and then once the DEXA scans results were back, we would see them in the community for assessment and treatment near where they lived, so it was very easy for them and they wouldn't have to come back into hospital for another visit. After their community assessment, they'd then be recommended therapies and then join the same monitoring pathway. A few other tips. If you're going to find patients, don't use one system. Use multiple systems, because no one system is great. So of course use the hospital record and electronic system, but also administration lists for clinics, and as well as direct visits to the clinic and the ward, just in case patients have slipped through. And then have an audit process. Maybe check all the orthopedic letters for 1 month, every 3 months, just to make sure you're not missing any patients who've been through the pathway. Your service may be seeing up to 3,000 patients a year, or maybe just 100 patients a year. It's very important that each patient has exactly the same assessment. This is important for not only treatment thresholding, but also excluding other diagnoses and guiding treatment choice. Have a consistent pathway for DEXA triage, and we've gone for a very efficient process whereby we only request blood tests if the patient is osteoporotic. We're now on to our 23rd version of our assessment tool, and you can see it here. This is very complicated but very comprehensive. We've minimized free text entry. The nurses now tick and fill in dates where needed for fracture site, risk factors of vertebral fractures, other aspects of fragility fracture assessment, including the fracs and dietary calcium intake. With all this information, we're now able to offer through the service therapy for nearly every patient. Drugs such as zoledronate and teriparatide have to be referred to the clinical team, as well as patients who have cancer and patients with chronic kidney disease. But 90% of patients can be managed within the fracture liaison service. And this has led to a real change in how patients are treated in the region. We have between 60 and 70% recommendation of alendronate by 3 months. Denosumab is our favored parenteral therapy, and this is increasing now year on year. With the recent health scare on strontium in terms of restriction of prescribing for people with cardiovascular and venous thromboembolic risk factors, we've effectively reduced our rate of strontium prescription to almost 0. And this is very important. We did this within half a day. As soon as the Medicines Agency came up with the recommendation, we told our nurses and they could immediately change what they recommended. Monitoring is a very important part of the system, and it is very difficult to achieve. There is no one perfect system, and that is our 3rd version. And basically we send out a letter. If there's no response, we phone them and we check a database we have of GP prescriptions. And then based on that, we send a letter to the patient and the GP. And the monitoring is done at 4 and 12 months after fracture for people on alendronate, and 7 and 13 months for those on denosumab. What are the outcomes? Because we ask about dietary calcium intake and don't prescribe routinely calcium supplements, we've been able to save the local health economy £40,000, or equivalent of one nurse full-time salary a year. Our adherence rates are very good. We're now finding adherence rates of up to 70 to 80% with this tiered pathway, and that's a major improvement if you don't include monitoring. The Oxford system is very complicated. It involves integrating patient records, questionnaires, bloods, and DEXA. And we were finding a lot of our specialist nurse time was being taken up with administration. So within our network, we paid for a database to be built to address this issue. This database is called the ELFIN system. It's defined by the FLS for the FLS, uses templated letters and multiple outputs. It actually doesn't mind which electronic medical or healthcare record your hospital has, and it's an approved NHS clinical care record system with open source design. And currently, actually, is now 12,000 patients are active within Oxford using this, and it's now in one other trust. It's really important to have a good information system. Not only does it make it very easy to enter patient data, so there are false risks, but also once you've entered the data once, you can output it many times. We have auto-templated letters for the GP, for the patient, requesting referrals and requests, as well as auditing and reporting. For the patient, we've designed a special letter, which has got their name, the risk of fracture before treatment, the risk of fracture after treatment, what they need to do now, what if they have a problem, and on the other side, the treatment choices in terms of drug, calcium, vitamin D, exercise, smoking, and alcohol. And we think this has really improved our patient. Another aspect is built into the ELFIN system is active monitoring. So we write to patients and phone them, and this is all scheduled within the system. And that way we pick up non-adherence, adverse events, and refractures which maybe haven't come to the GP's attention. This allows us to change treatment and really reduce the risk of that patient's therapy. The introduction of active monitoring was a real change for the NHS, which usually relied on the patient to initiate contact. So we did a very careful series of patient satisfaction questionnaires. The first questionnaire was about the amount of information that they were given at this time. And 88% thought it was the right amount, and 99% said that the specialist nurse was to answer all their questions, which is a real credit to the nurses. Finally, 89% would recommend this pathway to families and friends should they have a fracture. So the team is specialist nurse led, with specialist nurse practitioners, and a project manager set up the system, and administrators to run the system, with support costs for space, information technology including ELFIN, printers, DEXA scans, and phlebotomy, with only remote interaction with the doctors should there be any problems, and to provide training. We have a low turnover of staff, but when new staff do come on, they have a 2-week induction, a graduated introduction to the system, and the duration of the contract where we're allowed to look for probation periods. And then by this system, we can change nurses with little experience in osteoporosis and fractures to be fully autonomous and have mastery and purpose, and also be geared to relentless improvement in their clinical knowledge. This has now been supported by the National Osteoporosis Society Fracture Prevention Practitioner Training, which can be found on the NOS website. And this is an online learning tool at both foundation and advanced level that ensures that the quality of the knowledge of your fracture liaison nurses meets at least minimum and also advanced standards. And all our nurses are now accredited through this system. When you're appointing nurses, there's 2 things to bear in mind. Whether you go for part-time nurses or whether you go for one whole-time nurse. This one gives you flexibility to cover leave and training, whereas this one gives you continuity of care. And we found it's essential to have at least one full-time nurse within your service. It's also important to plan for peaks in activity rather than troughs. So this is our activity in 2014 and 2013, and you can see there is a monthly variation in numbers, and you need to make sure your service can meet those peaks in activity. So we have about 4 nurses for a population of 620,000 with 1.75 whole-time equivalents for administration, using the LFID system. Without LFID, we'd have to double the administrative load. So this is the economic model from the National Space Society showing us a total cost saving over 5 years for the service at around £5 million, which is a significant saving for the local healthcare economy, as well as benefits for the patient in preventing avoidable fractures. So what are our next steps? First of all, we haven't addressed the issue of spinal pelvic fractures, and we're now setting up pathways for that. We found that 17% of our patients were coming from managed care, either residential or nursing care, and they had very low rates of secondary fracture prevention. So we've now instituted a system whereby these patients are systematically found, and if, as is likely, they cannot tolerate oral medication, they're allowed to be started on parenteral therapy without needing to come for a hospital appointment. I get asked many questions when I set up a service. The first one is, how big a service do I need? This really depends on how you're going to assess and recommend treatment for patients, and also how you're going to monitor patients. Once you know how you're going to do these aspects, then you're able to see what size of service you'll need. Always plan for a slightly bigger service, because there will be times when people go on holiday leave, study leave, they may be on sick leave, or they may just rotate out. And training new staff takes about 2 months. So always add more staff to your service. It's far better to have a slightly more expensive service that does work than a slightly cheaper service that doesn't. Often there'll be other people saying they can provide secondary fracture prevention, such as primary care or maybe hospital services. And the best thing to do is offer them the opportunity to run a small-scale pilot to see if they can provide the service from identification, initiation, all the way to monitoring, and if they cannot, have an early review to try the system. And we did this with primary care and with ortho geriatrics before we came to the system that we have in place in Oxford. Almost there. The last thing is collect data. It is very important that you collect data to show how your service is running for 2 reasons. One, to show others that you have met certain criteria, such as a percentage of patients on treatment at 12 months. That can show that you're effective, but also to identify gaps in your service. For example, is the monitoring on time, or is it lagging behind? Is there a delay getting treatment recommendations to patients? So it's very important that you use local and also regional and national systems to collect data. And finally, share good practice. It's been a pleasure working with the members of the Frisky collaboration. Over the last 6 years, we've seen a substantial change in secondary fracture prevention, and we're now gearing to tackle vertebral fractures through a combined approach where we share knowledge between radiologists, radiographers, and the fracture liaison service. These slides will be available on the webinar for you to go back, but I hope I'll be able to show you that it is possible to link the patient with effective care pathway to reduce avoidable fractures, and the importance of providing data that the FLS has closed the care gap. I work in a very small component of a large team geared towards secondary fracture prevention. This is the team from the IOF, the academic team in Oxford, and our fracture liaison service. Finally, I'd like to thank Professor John Wass, who was inspiration in starting the service, Kay Rance, who helped me set up the next phase 2 of the service to where it is now, Professor Keith Willett, who's been instrumental in setting up hip fracture care and supporting the fracture liaison service in Oxford. This is the team at our last team photo, and I'm happy to take any question after Manju's presentation. Thank you very much.
Thank you very much, Kasim, for this overview of the UK system and your experience in setting up an FLS. Now, I'm going to give the lead to Dr. Manju Chandran, who is a senior consultant endocrinologist at Singapore General Hospital, and she will present her FLS called Optimal, which was set up in 2008, and like the FLS of Dr. Javed, her FLS has been awarded Gold Star, scored by IOF based on the internationally endorsed best practice framework. Over to you, Manju. Thank you.
I can't hear Manju.
Manju, we can't hear you. No, we can't hear you. Hang on. Make sure, can you make sure you sound, can you speak? Oh, hang on, I know why. Do not worry, everything is under control. Here it is. Now we
Okay.
can.
Okay,
Thanks.
good.
Sorry
Now,
about that.
right? Okay. Good. Good afternoon or good morning, everybody, depending on where you are, whether you're in Asia or Europe. It's about 4 p.m. here in Singapore, and thank you so much, Muriel, for that introduction. So, taking off from where Kasim left off, what I have been asked to do today is give a presentation on the secondary fracture prevention program in Singapore, specifically in Singapore General Hospital, which is the hospital where I work. And our secondary fracture prevention program is called Optimal. For those of you who are not that familiar with Singapore, we are this little tiny little red dot in Southeast Asia. We have got a population of about 5.4 million, and it's a very unique multi-ethnic population. We've got 74.2% of Chinese, which is the predominant ethnic population, and we also have Malays, Indians, and a small section of Eurasians. We're a totally 100% urban population. We really do not have rural areas, so it may be a little different from other countries. And our healthcare financing is based actually on the twin philosophies of individual responsibility and affordable healthcare to all. And we do have quite significant subsidies in healthcare provided by the government of Singapore. And this is actually provided through general taxation, as well as through, we have a nationalized compulsory health insurance plan called MediSave that can be used for chronic diseases as well as hospitalization bills. Now, 70 to 80% of Singaporeans actually obtain their medical care within the public healthcare system, and we have this unique concept of what are called restructured or corporatized hospitals. And primary healthcare is provided by a mix of about 18 polyclinics and 2,000 private GPs. So this is just to kind of give you a background of where I come from, and how our secondary fracture prevention program fits into the population of Singapore. And osteoporosis is actually a major public health problem in Singapore, and this is mostly because of a rapidly aging population. And what we expect is that the number of people major ethnic groups, which is the Chinese, the Malays, and the Indians. And we are fortunate enough to have DEXA services available quite freely, and we have about 27 DEXA machines for the population of 5.4 million. And thankfully, osteoporosis is recognized by the government of Singapore as a national health priority. So switching gears a little bit, there are plenty of osteoporosis post-fracture care management models available around the globe, but it still remains a big challenge to break the fragility fracture cycle. And what has been shown is that interventions based in public and healthcare education alone is unlikely to improve osteoporosis management. And like I said, there are many feasible models possible, but it appears that models based on a clinician champion and coordinator involvement circumvent the challenge of where the clinical responsibility resides in the care of the fragility fracture patient. Because till now what has been happening is that the fragility fracture patient gets into this Bermuda Triangle and nobody assumes responsibility. So a model which is based on a dedicated clinician champion, a coordinator involvement may actually circumvent this challenge. And now, especially in countries like Singapore, where healthcare is largely self-paid, though it may be subsidized, we do have to factor in the cost of anti-osteoporosis treatment when talking about, or even thinking about setting up fracture liaison services. So Optimal, which is our fracture liaison service in Singapore, it actually stands for Osteoporosis Patient Targeted and Integrated Management for Active Living. It's quite a mouthful, but it's a Ministry of Health funded program And we actually set up this program in the 7 government hospitals and the 18 polyclinics of Singapore in 2008. And the recruitment criteria are extremely simple. All the recruitment criteria is just that the patient has to be more than 50 years. It can be either a male or a female, and they should have had a fragility fracture after the age of 50. And by fragility fracture, we mean all major osteoporotic fractures, but excluding those, excluding fractures of the skull, below ankle, and beyond the wrist. And of course, we do not recruit patients with traumatic high impact fractures. And obviously, the patient has to comply with intervention and follow for at least a 2-year period. So it's a very highly facilitated multi-pronged program, the core of which is constituted by a clinician champion and a dedicated coordinator. We provide for case finding as well as education, recommendations for DEXA scans, basic labs like Kasim was talking about. We do recommend basic labs to rule out common secondary causes of osteoporosis. We recommend medications, which I'll be talking about in a bit, and we also have a provision for free physiotherapy sessions. And the physiotherapy service that we offer, it's called Otago. It's basically a fall prevention exercises, which is basically 10 one-hour sessions over 6 weeks, and this can be followed by recommendations for continuing either at home or the community gym, or the patient is free to come back for individual physiotherapy sessions over the next 2 years. And again, we are fortunate to have a data entry system, a centralized data entry system which works throughout the country called the centralized, it's called CCRD. And so this is definitely extremely useful in the program. So before I kind of go on to how Optimal was set up, there is some background information which I can share with you. And what we had was that before setting up Optimal, we actually ran a pilot project called HSDP project in osteoporosis management between the years of 2003 to 2007. And in that, what we did was we recruited about 1,000 patients from 3 hospitals across Singapore. And what we found was that before the HSDP project, when we did an audit, only 16% of patients were on appropriate anti-osteoporosis treatment after sustaining a fragility fracture. This actually improved to 44.9% after implementation of the HSDP, and we actually saw an overall reduction in fracture rate of about 42%. So how did we set up Optimal? So we identified the problem, and the HSDP pilot project helped us identify the problem. The next question was who would take charge. So for this, we actually, identified, I would call the mad people, but really dedicated and passionate clinician champions. And these clinician champions were actually given the freedom to set up the Optimal program in their respective hospitals in whichever way they felt best. And we also examined whether we should start from scratch or whether there were facilities and resources already available at each public hospital in Singapore. So there were several brainstorming sessions involved. All the clinician champions from the different hospitals met up several times before writing up, a project report to submit. And this was our proposal. Our proposal was allied with key strategic directions of the Ministry of Health of Singapore, which included risk stratification. MOH was insistent that we should base it on evidence-based guidelines. Case management is a very important provision that MOH insists on, Ministry of Health insists on. And we also had outcomes tracking, provisions for outcomes tracking. And we also set up some key performance indicators, which I think are extremely important before launching any program. And our KPIs were, number one, a reduction in patients who have recurrent fractures after sustaining a first fracture within the 2-year period, and we aim for a 40% reduction. This was based on the, the information which we had gotten from our primary pilot HSDP project. We said that our second KPI was that we would aim for an increase in the proportion of patients who have evaluation of osteoporosis and assessment of future fracture risk and receive appropriate treatment. We aim for an 85% on this. And of course, we also wanted to make sure that the third KPI would be adherence to treatment. And our goal for this was 70% adherence to treatment over 2 years. And we also came up with detailed expenditure and income projections. So armed with this preliminary data and the preliminary data that we had obtained from the HSDP pilot project and this proposal which we came up with, we lobbied the Ministry of Health for healthcare funding and top-level management at individual hospitals before setting up the program. So the very, very important thing which I think is crucial for any fracture development, fracture liaison service is to get good case managers or case coordinators. You can call them whatever you want depending on the country you are from, fracture liaison nurses, whatever. But what we did was we hired case managers and we had clear job descriptions set out, I mean, before starting the hiring process. And I really can say that this job is not for the faint of heart. And I really think I call my nurses demi-goddesses because they really are good at what they do. So I have to kind of say that the path has not been easy. I've morphed from this well-manicured person to this current probably frazzled, anxious person. But I think the journey has been extremely been fruitful. And what I would like to do is now in the next couple of minutes share with you what we have done at SGH, which is Singapore General Hospital, where I work at, and I'll talk specifically about the optimal program at Singapore General Hospital. Now, SGH or Singapore General Hospital is the largest tertiary teaching hospital in Southeast Asia. And we see about 1,600 osteoporotic fractures annually. And the advantage that Singapore General Hospital had when Optimal was launched was that the osteoporosis and bone metabolism unit at SGH had already started up an osteoporosis prevention and treatment initiative. So we really didn't have to kind of start from scratch. We had this base already, and we had just finished updating our hip fracture pathway at the time of Optimal implementation in 2008. And SGH has a unique advantage of having the most number of departments involved in buy-in for Optimal. And I think that's extremely important, as most of you who are probably in the process of setting up these programs will realize that getting people to buy into what you're trying to kind of promote is an extremely difficult task. And we also have the unique kind of distinction right now of having the most number of patients all the essential investigations, rule out secondary contributors to osteoporosis, as well as DEXA is ordered. Now, doing a DEXA is not an absolute, essential in patients with fragile fractures, but we do it and Optimal provides for it so that we can have a baseline to monitor the patient. As well as, the second visit is when a detailed falls assessment is done by the case manager, and then if she feels that the patient is deemed fit for physiotherapy, she does a referral. And the third visit is usually between the 6th week to the 3rd month, by which time the patient has been initiated in medications. And what happens then is that the case manager assesses compliance to medications, documents side effects, etc. And the 4th and the 5th visits can be either telephonic or for telephonic follow-up, or they can be direct face-to-face contacts, and these usually happen at the 9th and the 15th months. And again, the same thing happens. The case manager ensures that the patient is compliant to medication, documents side effects, any falls, fractures, etc. And she then orders a DEXA for the 24th month. In the 6th visit, which is essentially considered the completion of the first 2 years, which is at the 24th month, end of optimal questionnaire is filled out by the case manager after seeing the patient. So a very, very important part which I get asked often by people who are interested in setting up fracture liaison services are the costs involved. Now, I can only speak about ours and how much it costs to run the program here in Singapore and at Singapore General Hospital. So in general, when you talk about costs, there are non-recurrent costs, which would include initial training of personnel. For example, if you're hiring a case manager and if you're hiring a physiotherapist, IT personnel. So there's obviously going to be some initial training of personnel involved. Initial purchase of equipment, for instance, laptops. Our case managers are provided with laptops. Data entry software will of course cost money, and if you're planning on incorporating physiotherapy and falls assessment into your fracture liaison services, they might also cost a sum of money. And the recurrent costs, which for us at least at Singapore General Hospital, this is the manpower obviously. I mean the salary for the case manager and the physiotherapist. Now the case manager we have at Singapore General Hospital is a full-time person, and but the physiotherapist is actually considered 0.3 FTE. And obviously the rental of facilities or rooms to conduct the physiotherapy exercise, and then we have administrative, the cost for administrative support. Now, optimal at SGH, what we have done so far, we have screened about 7,000 patients up to date, of which we have recruited about 1,820 patients with fragility fractures so far. And I'm happy to report that 98% of these patients have a baseline DEXA, and 64.3% had baseline as well as 2-year follow-up DEXA. And we have actually reported on all this, including, just like Qasim is saying, the compliance rate to osteoporosis medications, which is of course notoriously poor. On our secondary fracture prevention program, Optimal at Singapore General Hospital, we've actually noted compliance rates of about 72%, which is very good. This is at 2 years, so using the medication precision ratio. So, and obviously, I mean, like again, Qasim said, I mean, it's important to audit your data, and that's one thing which we have consistently managed to do, and we have had quite a few publications on our secondary fracture prevention program at Singapore General Hospital, as well as we've been invited to do editorials and commentaries and all that. But all that is well and good, but I think it's also important to periodically look back and see where you could have gone wrong. No system is perfect. All of us run into challenges, we come across stumbling blocks and barriers, and we actually look back at the end of a 2-year follow-up period. We actually look back and where the ball could have been dropped, the system level challenges that we faced when running our program, as well as what were the failures or what were the negatives that we realized had happened. And one was failure to identify all fractures present in the hospital. Now this is probably a manpower issue too, because our hospital is a pretty big hospital, and it's quite difficult obviously to identify all the patients. And again, vertebral fracture capture is quite poor, which we realize is not just a problem isolated to us. I think it's a problem in several institutions across the world. And even if we did manage to evaluate a lot of patients, there were quite a few barriers to recruiting all these patients, which I'll talk about in a second. And we found that, decanding or discharging these patients once they were assessed, once they were put on treatment, sending them to polyclinics is rather slow. And in Singapore, in the public healthcare system, we have coined this term called right siting, in which we believe that patients with chronic diseases are best managed in a polyclinic or in a primary care setting rather than them filling up the hospitals. And this is called right siting. And we have found that, we have not been able to discharge these patients as effectively as we could. And of course, there are manpower issues, which again is a significant problem. Keeping these dedicated case managers on board and having enough of manpower to handle all these osteoporotic fragility fracture patients is a problem. And as far as patient level factors are concerned, why do patients fall off of the bandwagon? We've looked at this too, and what we have identified are several factors, of which, interestingly enough, at least for optimal, what we found was that 27% of our elderly patients, now you have to remember that these are all quite older folk, and these patients, actually 27% of them felt that the program was too time consuming and they had nobody to bring them back, for follow-up visits. So that was actually a big chunk of patients who dropped out. Very, very interestingly, and this was actually quite reassuring, is that we were concerned that, because of all these recent concerns about side effects of anti-osteoporosis medications, whether fear of side effects of medications could be a potential a factor for people to drop out of the optimal program, but actually only very few people, 4% of patients, dropped out of the program because of fear of side effects. And so I think anyone who's setting up a fracture liaison service is important to look back periodically, not just after several years, but to look back periodically and identify where all you could have gone wrong, some mistakes which you have made, and how you can rectify them. So in summary, the optimal program has succeeded in identifying, evaluating, and treating a large number of patients with fragility fractures at Singapore General Hospital. Like I said, we've recruited about 1,800 patients so far. And our program is highly facilitated. It's a multi-pronged program, and all these components appear to have contributed towards potentially decreasing the care gap in the management of fragility fractures. A high compliance rate with medications was seen, but of course the ultimate success of our program will be measured by fractures prevented over long-term follow-up as well as the cost effectiveness. And our goal is to ensure that no patient with fragility fracture is missed and that the first fracture will really be the last. And I really would like to acknowledge a few people, including of course the Ministry of Health Singapore, without which this program would not have been possible. And like I said, at SGH, at Singapore General Hospital, we have the unique distinction of having the most number of departments involved in Optimal who are interested enough to take part in this process. We have orthopedic surgery, emergency medicine, endocrinology, rheumatology, geriatrics, OBGYN. I'm an endocrinologist myself, so it took a while to get all these people on board, but we managed to do it. And of course, I really would like to thank the Optimal team at Singapore General Hospital. And now the last part, what do we propose is improvements in Optimal. We are going to be launching Optimal 2 in March of 2016, and a couple of things which we think we'll be incorporating into Optimal 2 is that involve the general practitioners also in Optimal. Right now it's only the polyclinics which are involved, the public polyclinics, but we would like to involve general practitioners, the private GPs also in Optimal. We plan to now, thankfully, recently in Singapore, MediSave, which is a compulsory health insurance savings scheme, which covers chronic diseases, has included osteoporosis as one of the diseases in it. So patients can make use of MediSave to cover some of the costs of treatment as well as investigations. And we also plan to integrate the orthogeriatrics hip fracture care management program running at some hospitals with Optimal. And how can we involve general practitioners? We plan on GP training courses to familiarize them with the Optimal program, the care coordinator can liaise with the GP or the family medicine care for follow-up, and the investigations, rather than being done at the hospitals, we hope that these can be done at the GP or family medicine care clinic at preferably the same cost. And like I said, this is going to be a key part of Optimal 2, in which we incorporate the orthogeriatric hip fracture care pathway with Optimal, and by this we hope that there will be an integration of seamless care, since the hip fracture care pathway runs down up to the community hospital and then Optimal runs down to GP. So we hope to bridge this gap with by involving the hip fracture care pathway also in this, and we hope that Ministry of Health will fund both programs together. And
Hello?
yeah.
Hi. Thank you very much. Manju, for this presentation. I'm sorry, we had some sound problems, but it's not working again. So apologize. Thank you very much for your patience. Thanks, Manju, for sharing your experience. And especially emphasizing that all about persistence and not giving up. Now it's your chance to ask questions for outstanding feedback. If you have any question about presentation, please type them in the question box. And we already have few questions. So the first one is for you, Kasim. It's about the IT system.
Yeah.
Is it available for purchase anywhere else than in the UK?
Yeah, we're just sorting that out. It's actually available on free academic license, so you can get it. It's written on a Java platform, and you can, if you're a public health or a university, you can use it. And if you need help with implementing it and modifying it, then get in touch with us, and we can see how we can help you with that. It's available, yes.
Okay.
Email me, and I'll give you more information.
Another question was about one-to-one partnership and coaching for any new FLS abroad outside your country. Is it something that is?
Sorry, what did you say, Mira?
I'm sorry. My phone is not working. Is there? So there's. Hello? Can you hear me?
Hello? Yeah.
Yeah, apologize for that.
I can hear you.
One of the participants about a potential partnership or coaching any new FLS
Yeah, it's a very important question. The IOF CTF program is developing a mentoring partnership. At the moment, what you can do is go on the IOF map and see if there are any gold stars near where you are, and also work with your national charities. But the IOF is hoping to coordinate this globally. Clearly there are some issues that are global and there are some issues that are national. Manju, what's happening in Singapore?
Yeah, so we would be more than happy to share our whatever knowledge and expertise that we have gained, and we would. I'm sorry. We would act. It's a lot of echoing here. So we would welcome, I mean, if people wanted to do a site visit, we'd be more than happy to kind of, show people around. As of now, we haven't formalized any partnerships with anybody, but we'd be more than happy to kind of share our expertise and also, like I said, if you want to come and visit, if anybody wants to come and visit for a half day or a day, kind of, see how a program runs, we'd be more than happy to. And we are in the process of setting up a few kind of workshops in the region. We get invited to kind of do whole workshops in the Southeast Asian region to actually just present our program, and I take along my osteoporosis fragility fracture liaison service care coordinators, and that's another way by which we'll be more than happy to kind of share more details about our program.
Thank you, Manju. And there's a question for you too, I guess, which is, how can I find help for local problems?
In the sense, is it for me?
I'm sorry. Oh, sorry. Where do they come from?
It's in Europe, but I guess in each countries, how would you identify who to talk to for problem in FLS implementation?
Unmuted. So in the United Kingdom, they'd go to the national charity, National Osteoporosis Society, and also come to us. And the key thing is to go on the CTF map and see if there's where's your nearest gold star, and go to them. That would be my advice. The IOF is planning to set this up as a system, as a mentoring process, and we're just searching for funding for that.
Yeah, I would say the same thing too.
Okay, thank you very much. One last question. What do you do if you have no national guidelines on osteoporosis patient care? What would be the first step to do?
Copy and steal from other centres. Don't write your own. It's too hard. It's too complicated. Just go to another country and just copy theirs, because at least then you can evidence base it. Otherwise, you'll spend a lot of time writing local guidelines. You'll have to put the evidence in, all the data, the papers, and at least then you can say we're using the Singapore national guidelines, the Scottish or the UK, and you just use that. It's somewhere to start with. If there are local changes, you can always amend it. What do you think? Is that reasonable, Manju?
Yeah, I would say the same. And you do have to have some local adaptation.
Yeah.
Like you said, you have to start off somewhere, and rather than trying to reinvent the wheel, especially if your government or your funding body insists on guideline, evidence-based guidelines, then you go for the one which you think would be most suited for your country or region.
Unmuted. I can't hear you, Muriel.
Sorry, this is the time. If you want to ask one more question. Another question is, what would be the key advice or aspect to make an FLS sustainable?
Measure everything. Collect data, make sure it's patient-centered, and be humble enough to know that what you started with may not be where you finish, and be ready to take painful decisions if that's what the patient's.
Manju?
Yeah, and I would add, in addition to that, I would probably add that the key components of a fracture liaison service would be getting somebody who's passionate and who's dedicated, a clinician champion, and get good case coordinators or managers. So without either of these, I don't think any fracture liaison service is going to last long. And as Kasim said, frequent audits of what you're doing is essential, not only to kind of help you understand where you could have gone wrong, but also to keep yourself on the radar and to make, to get your funding body or government agency, whatever it is, to realize that you are doing this work and this is important. So you can only show it through self audits, and I think those would probably be the key components. Having a clinician champion, having a case coordinator, and periodic audits.
Thank you, Manju. One last question. How many years I am waiting to see a reduction of costs? Secondary fracture prevention. In summary, the result of prevention. Is it calculable?
Unmuted. What was that again?
So how long do you have to wait before you get a reduction in costs, cost saving? So remember, it depends who's asking the question. If it's a politician or a policymaker, that's different to if it's a professor of epidemiology and health sciences economics. So tailor your data to who needs to hear it. I think for the policymaker, we've actually, although the drugs take 6 or 12 months to work, you can average out the benefits over 5 years as annual returns. In the UK, the break-even point for a fully comprehensively funded service is 18 months. So after 18 months of effective fracture prevention, you will start seeing a reduction in costs that will start to break even. The reason it's so short is that we include social care costs. So if the patient enters a nursing home or requires a lot of community costs, then it does make it sooner. But there's lots of papers on that. You can drill it down as much as you want, but always remember you're dealing with commissioners and policymakers who are not the same as the reviewers for Cell or Nature.
Yeah, and if I may add to that, for us, in Singapore, now that we're launching Optimal 2, we obviously had to kind of prove to the funding body, which is in our case the Ministry of Health, the cost effectiveness of Optimal 1. And so the program was set up in 2008, so that means it's now about 7 years out. And 6 years out. And last year we estimated the cost effectiveness of the program, and we were able to show, at least this is again like Kasim said, depending on who you're going to show the data to. So we were able to show the Ministry of Health that at least for hip fracture prevention, we have been able to kind of this is a nationwide program, not just Singapore General Hospital. We have been able to demonstrate a cost effectiveness, at least a cost avoided of about 2.48 million from this optimal prevention program in Singapore. So yes, you can start looking at those kind of data about 2 to 3 years after setting up the program. We had to show it actually to convince the Ministry of Health to support us for Optimal 2.
Thank you very much, Manju. So I think it's time to close this webinar. Many thanks for joining the webinar, and I hope that it has met your expectations. A big thank you to our 2 speakers today. A survey will be sent to you for feedback. Please, I would be very grateful if you could fill it. And if you have any additional question about FLS implementation or to our speakers, do not hesitate to email me. The email address is on the screen. Thank you very much. Goodbye.
Thank you.
Thank you.